Hello, and welcome to Exercise Etc's Avoiding Common Fitness Injuries. My name is Laura Abbott. You have probably heard me before, but if you haven't, here's just some information about my background. I currently teach at Georgia State University in the Exercise Science Department, and just some other stuff that, about me that you could read on your own at a later time, but it just puts a face with the voice for you, hopefully. And if you're familiar with our webinars before, or if you're not, just a couple of points I want to make on this particular slide. And the main part, one of the first bullet points here is right here. And this is just letting you know that you can get your certificate immediately following this webinar. So, and we'll have this slide up later if you haven't had a chance to print off the slides for you. And then the other one that I really want to kind of point out down here at the bottom is that I don't know how it does it. Technology is a mystery to me, but the WebEx program does record when you log on and when you log off. It can also tell if you fast forward at all through the presentation. So that may result in you not getting your continuing education credit. So hopefully I will make this enjoyable for you that you will just want to stay for the whole thing, get you some, information, maybe hopefully some new stuff and rehashing some old stuff. So just wanted to let you know that. And then the final little thing I do want to let you know is that you do need to make sure you complete this webinar and print the certificate by December 31st of this year, or the year that you purchased this program. So certificates with next year's date may not be accepted by your credentialing organization. So we just want to alert everyone to that. So learning objectives. The key points for this is that we want you to be able to identify the risk of ankle sprains, explain how to properly manage patellar stress syndrome, describe the difference between grade 1, 2, and 3 sprains and strains, as well as the difference between a sprain and a strain, provide appropriate exercises for the shoulder, and list methods to help prevent shoulder impingement. Now, we understand, too, that we have a variety of backgrounds that listen to these webinars. So we know that some of you may be physical therapists, athletic trainers. Others of you may be exercise physiologists with a degree. Others still may be fitness professionals with or without a degree, but with a certification. So I will make sure that I point out things that are within different scopes of practice so that we all make sure that we're doing what's best for our client at the time that they need some help. And just as a reminder, and this is really more so for the exercise physiologists and the fitness professionals, and I actually throughout this presentation will just lump that into fitness professionals. And I myself fall into that category. So we need to make sure that we do get a medical clearance and a physician's release prior to beginning an exercise program with any kind of medical or orthopedic concerns. Of course, the athletic trainers and the PTs, you guys follow your scope of practice, and obviously, especially with the PTs, you've got the medical information you need, which is how the person got referred to you to begin with. But when I mention things like that, and I'll remind you throughout this program, typically I'm talking about us fitness professionals that, we don't diagnose, we don't evaluate. We have certain things that we look for to make sure that we either can or cannot work with this individual. And when I say cannot work with the individual, it's send them to the doctor, find out what's going on to see if you or we as fitness professionals are the right person for them to see. Otherwise, we need to get them where they need to go. Excuse me. So, be aware of injury risk factors, and this is for all of us. So injury risk, of course, increases as the amount of training increases. We all are fully aware of that. We also know that for those of you who deal with athletes, whether it's a strength and conditioning aspect or athletic training, injuries are pretty much expected. at higher levels of competition, and that's just a different beast, especially if they're a professional and they're getting paid and that's their job. But when dealing with the general population, we need to look at things a little differently. And so we need to be careful from our exercise programming aspect that what we're doing is appropriate for our client. Higher levels of fitness protect against future injury if their higher levels of fitness are done correctly and appropriately. And again, that goes back to exercise programming. There's so much information out there, as we all know, and some of it's great information and some of it is great but not appropriate for all populations, and some of it's kind of goofy, crazy stuff that we don't really need anybody to be doing. And it's our job to differentiate that with our clients. We know that people see things on TV, they see things on the internet, they think they can do it because it's out there. And it may be a great exercise, it may be a great program, but it may not be appropriate for our client at this point in time. So we need to educate. It's really the big thing, is educate our clients, which means we need to stay educated. And then a history of previous injury is also a risk factor for future injury. And I'm sure the PTs that may be listening to this and the athletic trainers are probably shaking their heads, because you guys probably know who's going to come back as a patient in the future. And because they don't necessarily do what they're supposed to do. And the challenge is that they may complete their physical therapy program and get well, but then if they go right back to doing what caused the injury to begin with, they're going to come back. So I always tell my clients and I tell my students, it's not what your client does for the hour that you see them 2 or 3 times a week or once a week or however often you see them. It's what are they doing the other 24 hours of their day. So we'll get into that later on as well. And then smoking increases your risk. And we'll talk about smoking as an increased risk for back problems, but it's an increased risk for injuries for lots of different reasons. One is your smokers typically are not exercising. And that goes back to this bullet point right here, that if they are smoking and not exercising, they don't have that higher level of fitness, and so they don't have the musculotendinous and musculoskeletal ability to keep their body strong to prevent injuries from simple tasks. But also, too, there's a nicotine effect that affects the ability of blood to, or hemoglobin to bind to oxygen, not to get in all the physiology stuff, but it limits that amount of oxygen that can bind to the hemoglobin, which means that parts of the body aren't getting the oxygen that they need, which we know we need to have in order for tissue integrity. So lots of different factors play a role there. And then the most important factor for predicting exercise-related injury may be low aerobic fitness levels. Because we know that with aerobic fitness levels, the main goal is to help strengthen the heart and the lungs, but we also know we get some musculotendinous endurance and strength, we get some skeletal strength, we get other benefits along with the primary benefit of cardiovascular strength and endurance. And so, that kind of, again, goes back up to bullet point number 2, that higher level of fitness helps protect against future injury. So looking at common fitness injuries, and there's so many out there, we can't cover them all, but these are kind of the 6 biggies that we see. Ankle sprains, biggie, jumper's knee, ACL tears, back sprains and strains, and again, kind of differentiating between sprains and strains, just as a reminder that I always tell my students the T in strain and the T in tendon, and tendons attach muscle to bone, so strains are damage to the muscles and the tendons, and sprains are going to be to the ligaments. Fitness professionals, we don't deal with sprains. If we suspect a sprain, refer it out. We are muscles and tendons. So kind of keeping that in mind for later thought. And then rotator cuff tears. We know that shoulder is really unstable and moves around a lot, so it's very high risk for injuries. And then concussions. And just day-to-day stuff and life stuff, not just, fitness and exercise and sports. So let's talk about the ankle sprains here. So ankle sprains account for 1 out of every 10 visits to the emergency room. And that's pretty shocking, really, if you think about it. These are really bad ankle sprains that we're talking about where the person does need to go to the ER. We get a lot of blood vessels, nerves, and depending on the severity of that ankle sprain, those can be affected. You may have heard people say, or maybe you yourself, that you may have sprained your ankle so badly that the doctor says you would have been better off breaking it. So lots of stuff going on in this small little area of the body. And I saw something in a podiatrist office one day, and I thought, wow, I've been in this field for so long, and I just never thought of this that way. That you look at the number of bones that you have in your foot, and one foot contains about 25% of our bones in our body. And I was like, wow, because you got 7 tarsals, you've got 14 phalanges, you got 5 metatarsals. I mean, that's a lot. And the hands each hand make up almost the other 25%, but we don't use our hands weight bearing like we do our ankles, obviously. So they're, when they get injured and you're looking at all the ligaments that attach every single bone. And we got a lot of bones in that ankle, in that foot. So there is a lot of possibilities that if the musculature isn't balanced the way that it needs to be for strength, for flexibility, that there's a big risk of lots of injuries to that ankle. It makes sense. But it's just something, I don't know about you guys, but I just never thought of it that way until I saw this sign. And it just kind of pulls everything home. So acute ankle sprains, acute versus chronic, and usually acute is like within the first, as far as an injury goes, within the first 48, 72 hours. But then chronic is, of course, things that last longer, typically 6 months, or not 6 months, but 6 weeks, 3 months, where there are still issues. But acute ankle sprains need to be treated with that RICE principle, the rest, the ice, the compression, the elevation. Now, I always like to kind of mention the rest a little bit. Rest does not mean that the person rests their entire body. They can still, and with your help, they can still find ways that they can continue to exercise without using that ankle or that injured area in general. So, because there are some people that still need to exercise, and even, with physical therapists, their focus is the injury, but that's where the fitness professional needs to work with the physical therapist, and that client let the physical therapist work with the injury, but the fitness professional still needs to help that person continue their exercise while resting that injured site or injured limb. Because again, you may have a client that has diabetes, high blood pressure, or some other type of disease where they still need their exercise to help keep that disease under control. A lot of times clients think, oh, well, I can't do anything. Well, no, not necessarily. We just need to sometimes get creative with that. Later on, there is something called MICE, M-I-C-E, and that's where we're going to be talking later within everybody's scope of practice, where we need to add movement, which is the M, and rest or ice, compression, elevation. And then, of course, sprained ankles often heal with residual weakness that must be addressed. And this kind of goes back to, well, what the heck caused it? Was it a strength issue? Was it a flexibility issue, which typically they go hand in hand? So then your next step is to find out, well, where's the strength issue, which muscles? Where's the flexibility issue, which muscles? So when we're looking at ankle sprains, we have a first, second, and third degree, of course, like with any ligament or strain. And a grade 1, of course, is a partial tear. But for the most part, it's held together. It's usually with the first degree, the ligament is stretched, but usually not torn. There may be a smidge of tearing, but for the most part, it's still connected. The problem is that once the ligament stretches, it does not go back to its original resting length. So there's always going to be some instability there. And that's where now the muscles and the tendons need to kind of take over and pick up the slack from that ligament. A grade 2 is typically a tear of the ligament, but again, it's still intact. So it may be up to 50% torn for a second degree. There's also a 2+ tear where it's almost completely torn. It's almost a third degree, but there's still a little bit of connection there, but usually that's just treated as a third degree at that point. But a second degree does not always require surgery in the sense that the doctor needs to go in there and reattach things. So because the ligament itself is for the most part connected, the parts that are torn can kind of find each other and reconnect. But it still means that that ligament is longer, lengthened, than it was before when it was 100% healthy. So something else has to pick up some slack, and that's going to be your tendons and your muscles. Your first degree tear in an ankle sprain is typically a partial tear of the anterior talofibular ligament. And what I love about ligaments when I teach anatomy is the ligaments are typically named after the two bones that it connects. So your talus bone, your fibular bone, the ligaments that connect those two bones is partially torn, but that's the only thing that's kind of partially torn, which is now getting into a grade 1 ankle sprain. A grade 2 ankle sprain is a complete tear of the anterior talofibular ligament with the calcaneofibular ligament intact. Then a grade 3 ankle sprain is a complete tear of the anterior talofibular ligament and a complete tear of the calcaneofibular ligament. These are typically, the grade 3 is typically rare, and you know when you got a third degree ankle sprain because everything is swollen. The joint capsule that surrounds all in this area to help hold the synovial fluid has basically, oops, didn't mean to move it, meant to explode it. Well, I'm still moving it. And all that synovial fluid starts to leak out, and they're swollen down to their toes. They're swollen up to maybe the mid-shin. And that pretty much tells you they probably have a third degree ankle or grade 3 ankle sprain where they've pretty much torn the two main ligaments holding it together. And fitness professionals, those are the ones we say, go to your doctor. You need to get more care than in our scope of practice. So how can we prevent some of these, or what do we do for the person who has chronic ankle sprains? And I always think of runners that they're running along and all of a sudden they hit something wrong, they roll their ankle, and it happens all the time. And they're maybe still able to continue running, but there is a problem there and it needs to be focused on. And so with the stability training, one thing that really is something for us to consider, we know that we need to wear our shoes in the gym and the fitness facilities for safety purposes, which I kind of giggle at that sometimes because, you know, if you drop something on your foot in the weight room, that shoe ain't going to help you a whole lot. But our shoes, the design of shoes nowadays are so specific to foot issues and helping to stabilize your foot in that good neutral position that sometimes our muscles don't remember what to do if you don't have your shoes on. So this picture on the left I love because they're barefoot. And I know people who have gone through just doing this standing exercise on an unstable surface, whether it's the Dynadisc over here, a foam mat, and you ask them, where are you feeling it? And they won't say, you know, oh, in my ankle or in my knee or in my glutes. They'll say, I feel it in my lower leg muscles. And that's a way that the body's saying, you don't use us enough because you're always wearing your shoes. So if you're able to find some places in your facility where it's okay for your people to be barefoot, you know, keep the socks on, that's fine, but take the shoes off and do some of these exercises with just the muscles, controlling it, the proprioceptors, all that good stuff, then that in itself can be a challenge for a lot of people. And if you work with older clients, they may tell you, oh, I never take my shoes off because I don't feel stable with them off. Well, that's a sign that they need to exercise without their shoes on, because the shoes are doing everything that the muscles should be but aren't. The other thing to kind of keep in mind with some of this is most sprains occur in the frontal plane. So make sure that you include stability challenges that would be appropriate for strengthening in that plane. Now, this picture on the right, great exercise to do. Progression is important, and the way that, of course, you would progress this, take the shoes off and have them do it with just, you know, they're not on a Dynadisc or anything, and of course progress to this, but he's got his shoes on, and I really think that this would be a more applicable exercise with better progression if their shoes are off. So something to consider. So resistance band eversion and inversion, people do not always have an anchor or something strong enough where the band can be positioned away in this direction or on the other side in order to reverse the movement. So this is a really nice little way that you can use your monster bands and just figure eight it around the ball of the foot and then hold it depending on which direction you need for the anchor to be. But working the fibularis muscles, they're not big, strong muscles. We know with ankle sprains that the medial side of the ankle joint itself, or actually the medial malleolus, which is the distal end of the tibia, has a nice, big, strong deltoid ligament, whereas the lateral side of the malleolus has tendons. And we know that tendons have to have more elastic properties than ligaments because tendons attach muscle to bone, and the muscles need to move, therefore the tendon does. So we tend to be weak on eversion, and that is an exercise that really needs to be incorporated into everyone's repertoire to help keep that ankle a little bit more stable. And then as far as kind of moving on to patellar tendonitis or jumper's knee, this could be caused by a lot of problems. So we have to, and I think our field has done a really, really good job over the past, I don't know, 10 years or so of doing whole body analysis. And there's so many different ways that you can do it. There's so many different books out there, and it really, I think it's good to take a little bit of each method and incorporate it depending on your client and their needs. But there's the deep squat mechanism, the corrective exercise program that is through NASM. There is just general postural analysis, which I tend to teach a lot to my anatomy students because it helps them learn anatomy a little bit better and how muscles work together to balance. There are all kinds of different ways. Great Cook, I think, is another one that is a wonderful methodology. But my point is that it's not the knee necessarily that is the cause of the problem. It's just showing the symptoms. And we really, anytime with any injury, we need to look above and below the injury to see what's going on. Jumper's knee tends to be weakness with eccentric contractions. So your person may be very strong in the quad on concentric lifts, the up phase of a squat, the up phase of a leg extension. It's the lowering phase that they tend to have trouble with. And that is something that they need to focus on to help strengthen their muscles from an eccentric contraction standpoint, because when you land during a jump, it is all eccentric contractions on those primary movers. But we can't forget about the glutes. And often that is kind of forgotten because we think, well, the glutes don't cross the knee joint, so they're not really going to have an effect. Well, they are going to have an effect because when you do a jump, your primary mover is going to be, or movers is going to be the quadriceps and glute max especially. So if quads are fine, but the glutes are weak, it's still going to affect your landing mechanics. So we can't forget about primary movers. So the tendency is to focus on quads with the knees and hamstrings. And that, yes, that can definitely be a problem, but let's get those glutes in there. So something else that you can also focus on with jumper's knee is, it sounds like a disease, but it's terminal leg extensions, and I will talk about that as we get into this next slide, because it's a movement, it's the last 10 to 15 degrees of knee extension. And we don't commonly do that in exercises because it is viewed as quote unquote locking the joint. Well, you don't have to lock the joint to get those last 10 to 15 degrees. But, you know, if you don't go through full appropriate range of motion on an exercise or a movement, then you're not strengthening the entire muscle. And notice I didn't just say full range of motion, I said full appropriate range of motion. So how do we do all that? Well, strengthen and stretch the quads, strengthen and stretch the glute max, which is not up here. So let's type in glute max here. And why glute max and not the medius and the minimus? Well, glute max is your bigger hip extender. And like we said, weakness in that area can lead to compensations, and compensations can lead to injuries. Glute medius and minimus come in later as far as stability goes because they're more hip abductors. So we're not saying ignore those. We're just saying, you know, let's strengthen what is probably the cause of the problem first, get the knee pain and the knee issue under control, and then let's take a look at everything else. So also managing volume and intensity on patellar loading. This gets into a lot of discussion, which is not necessarily a detailed purpose of this particular webinar, but there are other webinars. I'm not trying to sell you anything, but there's lots of other information, not just exercise, etc. webinars that also get into full squat versus not full squat and who's appropriate for what. And in a nutshell, basically what I tell people is to look at the client, look at their sports, if they're an athlete, look at their activities, and look at their occupation. Full squats are necessary for people who are in body powerlifting because that is the position that they have to get into for their sport. Now, whether it's appropriate for your general population clients, you need to look at those other 23 hours of their day that we were talking about. And if they need it for their job, you know, maybe they're in a physical labor-intensive type job, electrician, a roofer, or something like that, then it might be beneficial for them. Is it something that you need to start doing right now? Maybe not. You're probably going to have to build them to that. And if they have a knee issue, you definitely don't need to be focusing on deep knee squats. You need to be focusing on these other issues that we're talking about, the quads, the eccentric contractions, not just of the quads, but also of the glute max. Is there a balance? Is there a balance between the quads and the hamstrings? Is there a balance between the gastrocnemius? Because that's another muscle we tend to forget about when it comes to the knee. Gastrocnemius helps the hamstrings flex the knee a little bit because gastrocnemius originates on the posterior condyles of the femur, crosses the knee joint. It is involved. And then if you've got gastrocnemius issues, do you have other lower leg imbalances and issues? And now we're back to that ankle. So because if your person has range of motion issues with their ankle, which, whoop-hoo, hello, goes back to these ankle injuries, then that can be causing or contributing to the knee problems. Which came first, we don't know, between the knee and the ankle. But we are all connected. We really, really are. So if you have somebody, and if you're looking at this picture right here, the leg, the lower leg has gotten closer to the foot. So that is dorsiflexion of the foot. And my students a lot of times have a hard time seeing that. It's like, look at the lower leg in relation to the foot, and you'll see that there is some dorsiflexion there. And if you don't have good range of motion at the ankle joint, then you're going to compensate. And that compensation may end up being a knee problem. It may end up being a hip problem. So this is kind of going back to all the different postural analysis and movement analysis. If you aren't trained in that, get trained in it. Because what I have noticed, I've been in this field for 30 years, and I'm guilty of this too. We were trained to look at the injury. My master's degree is in athletic training. I'm not an athletic trainer now, but I was a long time ago. And we tend to, back then, we tended to look at the injury and focus on the injury. And then it kind of dawned on us, oh, hey, we always tell everybody everything's connected, but we're not treating people as if everything is connected. So we do need to look at that, and getting trained in some type of postural analysis or exercise movement analysis is so important if you're going to be in this field. So some things that we can do to manage it. Well, let's limit squats to parallel for a while. Or you may have a client that just doesn't need to be doing weighted squats at all right now. Let's bring them back to body weight. Sometimes people view that as a regression, but sometimes it's better to present it in a positive standpoint with your client. No, we're just reassessing how you're doing your squat. If you have been performing your squats with a heavy load improperly all this time, you were bound to get this injury. So let's go back to the drawing board and let's get your body mechanics down. We've done a movement analysis on you. We see where you're weak. We see where your range of motion is limited. We're working on that. But because we're making those changes, we need to go back to the drawing board and get your squat mechanics down as perfectly as we can without any weight, and get that muscle memory back going, that brain and muscle connection, so that your brain can sense when you are out of whack, because right now it can't. So we need to re-educate these muscles, and we're not going to do that with a bunch of weight. And we need to really watch form. And I know you guys know that. I know everybody knows that, but I cannot tell you how many times when I'm at my gym working out and I see trainers working with people and they're on their phone. They're not paying attention. They basically are the repetition counter. And that's the person I'm like, you either need to go to a continuing ed program and brush up on something new because you're getting bored with your job, or you need to find something else to do with your job. Because your client has been doing these last 8 repetitions incorrectly and you didn't catch it. So don't be afraid to stop your client and say, whoops, you lost form. Let's get you back into proper form, and let's see if you can do one more correctly. And if you can, great, let's try another. If you cannot, then you're done. Your muscles are saying, we're tired, and that's your last repetition. But we have got to correct this movement, or else they're going to continue to have these problems. The next bullet point here, we need to keep maximal knee flexion to 90 degrees during step-ups, during lunges, during squat, incline squat racks, leg press, everything. A lot of times our clients, especially if they're working out on their own and you're only working with them periodically, they think, oh, I'm lying down on a leg press machine, so it doesn't matter here, does it? Well, yeah, because it's the same motion, and it's just instead of having the weight on your shoulders, such as in a squat rack, now the weight is pressing against your feet because you're in a leg press machine of some sort. But the rule still holds. We've got to educate. If you have a client who is a cyclist, and maybe you are not the best person to make sure that the handlebars and the seat and everything is properly adjusted, recommend that they get a professional bike fitting. Most of your stores, REI and any other stores that focus on bikes, they're going to probably have somebody who could do that for you. Or go to one of your cycling organizations, and if you haven't, make some good contacts over there so you can refer some of your clients. Because that bike fitting or the person who teaches your spin classes or whatever indoor cycling classes, they are most likely trained. If they're certified in that, they should have gotten some training on proper bike fitting. And educate your client, because it's not just their outdoor bike, it's any stationary bike that they need to make sure that they adjust properly. And then avoid, if they're cycling, avoid or limit time spent in high gears and hill climbing, because that is a lot of eccentric contractions, pressing that pedal down against a lot of resistance. And that's like doing high intensity strength training over and over and over again. And we wouldn't recommend that with strength training. Therefore, we should be carrying that over into other activities that have resistance adjustments, such as cycling, whether it's stationary or outdoors. And that also goes for downhill running, if they're a runner or a walker even. So we need to not only relate what they need to do that's causing the injury or causing the pain, but we need to relate those similar movements to what other activities in their life are going to be affected by that. And then, of course, going back to that Rice principle, even with chronic injuries, even with injuries that are healing, there's still going to be some swelling, so they still want to do that Rice activity, at least ice it after activity. So let's move on to your ACL and some other ligament sprains. And I always kind of giggle in my anatomy classes. I kind of work from the head down to the feet in my semester, and usually by the end of the semester, students have gotten to know each other and they're more comfortable asking questions in class. And boy, when we get to the knee, you hear about everybody's injuries in there. And so my point being is that people usually know the knee really, really well, regardless. And maybe even some of you listening to this have had your own knee injuries. Hope not, but sometimes that's why we choose to get into this field. So just want to kind of review then the anatomy a little bit, just make sure we're all on the same page. So your knee ligaments, of course, ligaments as far as fitness professionals and movement and all that good stuff, our ligaments are really there to help stabilize. And so like we were talking about earlier, if you have a damaged ligament, it can't do its job, and then something else has to take over, and that something else is going to be muscles and tendons. And if they're not ready to take over that job, then those muscles and tendons are going to compensate, and you're going to have form issues. They may be minor in the beginning, but repetitive motions that are not properly done are going to create injuries. So again, we got to look at the whole body when we're dealing with any knee injury as well, like we've been talking about. So your stability of your knee, it's very dependent on powerful muscles. They act as restraints, so to speak, quads, hamstrings. They've got to have that proper balance, and that proper balance isn't just balance of strength. It's got to be balance of flexibility as well. And because one of your quad muscles, rectus femoris, crosses that hip joint, then you have to look at the glutes as far as balancing your hip flexors and your hip extensors. So your four ligaments, of course, I know you guys know this, but your medial collateral ligament, or the MCL, prevents the knee from buckling inwards or valgus injuries. And that, again, can go down to foot problems, arch problems. You got somebody with low arches, they're going to be walking more on the medial side of their foot, and that's going to add more pressure to that medial collateral ligament. Your lateral collateral ligament prevents the knee from buckling outwards, or varus injuries. The person who looks like they just got off a horse. And that, of course, if you look at wear and tear patterns on their shoes, they're going to have more wear and tear on the lateral side of their foot. So again, you've got some ankle and lower leg issues that are contributing or being sacrificed possibly because of what's going on. And then your anterior cruciate ligament, the ACL, prevents the tibia from sliding forward. And I always tell my students, when you're looking at the name anterior or posterior, look at the tibia. So if your foot is planted and the tibia continues to move forward, or like in football, your person gets hit in the thigh and the femur moves backwards, so the tibia is still anterior to the femur, then that's going to tear that ACL. The posterior, of course, is going to be the opposite. Excuse me, it prevents the tibia from sliding backwards in relation to the femur. We don't see posterior cruciate injuries as much, and typically, because of the movement that has to occur, typically when we see posterior cruciate ligaments, the person may have fallen on their knee, and it caused the femur to push backwards against the tibia because the tibia hit the ground and the femur ended up moving because of the force of the body during the fall. If somebody's falling on their knees, you may see it in car accidents where the knee is bent because you're sitting in your car and the dashboard hits the femur and pushes it backwards. You may see it in other traumatic type injuries like ski accidents, but the car accident, the falling on the knee, those may create an isolated posterior cruciate tear. A lot of times, though, when you see posterior cruciate tears or sprains, there are other ligaments involved. So not a good thing. So together, these ligaments also provide rotary stability to the knee, which is also important in running sports like football and soccer, where there are certain cutting movements or changes in direction that are quick and fast. This also kind of led to when I was in the field back in the 80s and all the stadiums for football and soccer were switching over to AstroTurf because it was less expensive for upkeep. But then they realized it was more expensive for rehab for their athletes because unlike grass, AstroTurf doesn't give. So you're wearing your cleats and they're digging into the AstroTurf and now you've planted your foot and you have a cut or a switch in direction and your foot doesn't go with it because it's kind of locked into this artificial turf. It was creating more injuries. So it's interesting that stadiums are going back to natural grass. So gotta, if you ever get into the sport administration field, you gotta look at the overall picture when you're looking at things like that. That costs a lot of money to go back and forth. But what does your doctor need to do about your ligament injuries? Well, for fitness professionals, if we suspect a ligament injury, refer it out. Send them to the doctor. Gotta go. Out of our scope of practice. We need to know what we're dealing with, and I cannot tell you how many times as a degreed exercise physiologist I've had clients think that I'm also a physical therapist because physical therapy, I guess, is more well known than exercise science, and I have to correct them a lot of times. So our goal is to make sure the client is in the right setting for their treatment and their care. So ligament injuries, they're very common in adults and mature adolescents, but they're less common in young children because in children, the ligaments are stronger than the epiphyseal plate. So unfortunately, we would see more fractures in young kids than we would ligament damage for that reason. And of course, if they damage that epiphyseal plate, that's not good. But that's not the focus of this presentation. X-rays will help distinguish, though, if the epiphyseal plate injury in a child or an adult has been damaged. And also, too, and sometimes people get mad when they say, well, I know it's a ligament, but my doctor wanted to do an X-ray. And why not just go ahead and do the MRI? Well, they got to make sure there's no fractures or anything there either. It's not unheard of to have a tibial plateau fracture, which is the superior surface of the tibia, along with an injury, especially an ACL injury, because that's where it attaches, that tibial eminence, the two little points that stick out at the center of the tibia. You've got your, and I'll draw this here, you've got your tibial eminence right here. There's your tibia. And, well, if it's going to let me draw the rest of it without moving it. And your femur, of course, coming down this way. Well, your ACL, if I can draw my line here without moving stuff, is going to attach right here at this point, up here at the femur. And if you tear that ACL, you may take some of this along with it. So they got to check to make sure there's no fractures first and let those fractures heal up before they start sending somebody to physical therapy. So yeah, the X-ray comes first. There is a reason. Your grade 1 and grade 2 sprains can be treated conservatively because, like we mentioned before, a grade 1 sprain, not to be confused with the grades of ankle sprain issues or ankle injuries that we were talking about earlier, but just a sprain to a ligament. Grade 1, we said earlier, is that it's stretched, but the fibers are not torn. So they may be sent to physical therapy to learn exercises to help with any imbalances because, like we've been saying, muscles and tendons now need to kind of take over some of the stability for the knee. Grade 2 is where the ligament is partially torn. And like we mentioned earlier, a lot of times if you baby that knee, those ligaments that have been torn can kind of find each other and reconnect and heal back up. Grade 3, though, ligaments completely torn, there's a lot of instability, they're going to need to go in and get that surgically fixed. And how it's surgically fixed depends on how torn and shredded that ligament is. If it's completely shredded, they may need to go in and completely replace the ACL with another structure in the body. They may be able to reconnect those fibers. I mean, it just depends. And that's a conversation that you have with your physician. So the grade 3 sprains usually take about 12 weeks to heal because they have to have surgery. They have to be casted afterwards. The muscles have atrophied all around that area. Scar tissue has built up, and that's PTs and athletic trainers. And, you know, once all that is fixed as best as it can be, and they are getting their movement back and range of motion back, then it may be time for them to go back to their gym and work on that knee from a maintenance standpoint. And that's where it's very important for PTs as well, PTs to work well with fitness professionals, athletic trainers, to work well with your strength and conditioning team. So, women and ACL injuries. Women tend to be 3 to 6 times more likely to have an ACL injury than men. And this list right here is explaining what the bigger reasons are. Estrogen, those darn hormones. Women have the highest risk of ACL injuries at the time of ovulation, which is typically 1 to 2 weeks prior to the menstrual cycle. Some studies may say pre-ovulation, other studies say during ovulation, and oral contraceptives may actually decrease that risk by about 20%, but there is a lot more research that needs to be done on that to really determine that benefit, because of course oral contraceptives have other risks. So teaching females proper landing mechanics, when the hamstrings need to fire in relation to that is so very important. And you can really see the difference if you go to a high school basketball game where usually the women's game is first and then the boys' game, or the girls' game is first and the boys' game is second. And there's just a big difference in form and intensity. And so with women, one of the challenges, and girls, is they're not taught proper squats. And women tend to, there is a point in time where the ACL, during the entire movement of flexion and extension, where the ACL is relaxed or lax, then it's taut, and that's when it's at the greatest risk of injury, and that's usually around about 120 degrees of knee flexion, somewhere in that ballpark. And then, of course, when it's fully extended, it goes into that little lax area. So with the area where the, I said that backwards, where it's taut at extension and it's lax at about 120 degrees, so I apologize for that. So my point, though, is that when women, looking at basketball and kind of getting into the improper squats that women are not corrected on or not taught, is girls in basketball don't get into a good deep squat to get into a good blocking position during basketball. They're in that 120 or so degree knee flexion where the ACL is the most taut. And if somebody hits them when they're in that position, they're more likely to tear their ACL. So we need to get them into that deeper, lower squat position for blocking in basketball or any other sport that they play, where that position needs to be corrected. That also helps to get the hamstrings to fire more, because in women especially, but in guys also, that goes into when do the hamstrings fire. And if they're not firing properly, then the hamstrings and the quads cannot work together to help keep that knee stabilized. When it comes to boys, and I know this slide is about women, this is where understanding anatomy is so very important. And I cannot tell you, even with my students, that in their 2000 level anatomy class, they still have it in their mind from their coach in high school, whether it was at their school or outside of school, that squats work hamstrings. And yes, but how? Hamstrings are never worked in a squat or a lunge or a leg press as a primary mover. And we have to remember that. Quads and glutes, those are your primary movers in a squat, a lunge, a leg press, any of those movements. Hamstrings are either a synergist at the hip with glute max, or they are an antagonist at the knee with the quad. They are never, never, never a primary mover. But the problem is, and this is true with women, but also with men and kids, is if their strength and conditioning coach or their person who's working with them does not understand that one little point, then what happens is hamstrings are never worked as primary mover because they never do a hamstring exercise, because they keep telling their kids, oh, you're strengthening hamstrings doing a squat. Well, you're not, to the extent that you need to have that good balance between quads and glutes. So they end up strengthening the quads more and more. Hamstrings continue to get weaker and weaker. They end up having knee problems. They end up having hip problems. Hip problems lead to back problems and modifications in their movement, which can lead to ankle issues. Yes, we are all connected. And then, in boys especially, they start developing something called Osgood-Schlatters disease, which is where the tibial tuberosity, where the quadriceps insert, start to pull away. The muscle tendon starts to pull away from that point, and the tibial tuberosity is saying, hey, wait up for us, and it starts forming more bone. And now they've got this big, huge, knotty tibial tuberosity that's very, very painful. All because whoever was working with them in their strength and conditioning atmosphere did not understand their anatomy. So we have got to explain and educate that to whoever we're working with. They have got to do a hamstring exercise, strength exercise, where hamstrings are primary mover. That can be your seated leg curls. That can be your prone leg curls. We've got to do that, or else these individuals are going to continue to have these problems. So really understanding anatomy is very, very important. So I beat that horse to death. So let's look at the femoral notch. You may have noticed that some women tend to be able to extend their elbow, and it kind of looks like it's hyperextending. Women tend to have deeper notches. And notches basically like the olecranon process and the olecranon fossa, the elbow, the process when we extend the elbow fits nicely into the fossa on the ulna. And if women's are deeper, then that process has further to go, and it looks like they're hyperextending their elbow. Well, we have something similar with the femur. So again, with your femur, here is your femur. That was a very sad-looking femur there. And you've got your notch right here on the femur. Well, with women, you may have a notch that is, and that's going to be kind of sad-looking, but it's much, much deeper, which now means when you're looking at the tibia here, and I hate that my little mouse won't let me connect the line. Now you've got this issue where your ligaments, especially ACL and PCL, are really having to stretch further, move that a little bit, in order to attach to the tibia. So that has them in already a very taut position to begin with. Then all the other things that we were talking about, hamstring firing, landing mechanics, getting them into a good squat position, because there are points in knee flexion and extension where the ligament is lax versus taut. All of that is an even bigger problem. Now, we can't fix the condyle, but we can fix the hamstring firing and teach proper landing and blocking mechanics. So again, food for thought there. Q angles is another problem, and that's something else that is more structural, meaning it's just how their bones have grown, not necessarily something we can fix, but it's something we might be able to quote-unquote control a little bit by having a good balance of strength and flexibility. Your Q angles with your person, if this is looking at the client's pelvis, and you've got your femur angling in, wow, that was really a lot. So that valgus position with the knees tends to be more common in women. And the reason is because we have a wider, more flared, I wouldn't say wider to a woman, but a more flared pelvis. And what we mean by that is the iliac crest is flared out more in females, where the iliac crest and the ilium bone itself is more upright in men. And of course, that's how you tell a skeleton whether it's a male or female. Because of that, the femur, the head of the femur going into the acetabulum of the pelvis, on the where all the bones meet, the actual hip joint, tends to angle the femur down and out a little bit more. And because it's angling the femur, the head of the femur down and out more, because the ilium bone is flared down and out a little bit more in the female pelvis, then it pulls the femur inward the more distal you go on the femur. Well, it's got to straighten out somewhere so we can stand on our feet properly. So what happens is you have this valgus or knock-knee position because the tibia wants to balance that out. So like we mentioned earlier on a previous slide with MCL, medial collateral ligament here. Let's say this is your fibula, so this is the lateral side of the knee. This is the medial side. Here is your medial collateral ligament, actually right here in this slide. So the more force you have angling the femur at an angle, then this area right here is going to open up more and put more pressure on that medial collateral ligament. Now, how does that relate back to the ACL? Well, your ACL, which is shown right here, merges in with the medial meniscus. And the medial meniscus, as you can see, and actually let me erase this right here and go back to here, you can see that there's not really a gap between the medial meniscus and the medial collateral ligament. They are literally connected. So that's the terrible triad, or the unhappy triad. Is a pretty darn serious knee injury where the ACL gets torn, the medial meniscus gets torn, and so does the medial collateral ligament, because they're all connected. Now, the posterior cruciate ligament does not connect to the lateral meniscus. And the lateral meniscus, and this is angled a little bit in this picture, but there's typically a gap between the medial meniscus and the lateral collateral ligament. So they're not directly connected. So you can have an isolated tear there. But with ACL, medial meniscus, medial collateral ligament, it's not uncommon to have all three of those torn. And those Q angles put a lot more pressure on that medial collateral ligament. So that pressure, because of the connection, can lead to higher ACL tears. And then fatigue, you know, simple. We get tired, we start losing form. So conditioning your athletes, conditioning your amateur athletes. You know, you may have runners or cyclists that they're not professionals. They just enjoy it, so they like to do races. Make sure that they are properly cardiovascularly trained so that they can build up some muscular endurance as well as the heart and lungs, like we were talking about earlier. Cardio exercise has some muscular benefits, skeletal muscle benefits. And one of those is to help build up endurance in those muscles. So that may help lessen fatigue. Keeping the heart and lungs strong can help lessen fatigue. And all of that can help maintain proper form during activities. So you may have some of these kids that are in sports such as soccer. There have been some really interesting research done on soccer players, and depending on what position the soccer player plays, they may run up to 6 to 10 miles per game. But here's the thing. It's not the typical cardio program as a runner who goes out and runs a straight 6 to 10 miles. There's some stop and go. And you watch any soccer game, yeah, there's lots of running and lots of action, but there's also lots of light jogging and, you know, not so much walking, but it's still more interval. And so we aren't saying that, hey, if you're playing soccer and training, you're getting your cardio exercise. Well, not really. You're getting a lot of stop and go exercise. We still need to make sure that they're maintaining some good, straightforward, long cardio program to keep that fatigue at bay during a game. And that comes with their coach, if they're college or professional, their strength and conditioning team, to make sure that especially pre-season, maybe a little off-season, they're doing some cardio exercise that can last 45 minutes to an hour, a little longer because they're athletes. So we don't want to poo-poo the endurance or cardio exercise in some of these stop-and-go sports. So your best practices to help prevent ACL injuries, we kind of hit on this already, but strengthen the hamstrings in an exercise where your hamstrings are the primary mover. Improve jump and landing mechanics, which we're going to talk a little bit more about that coming up, but teach proper landing. A lot of times people think they don't, I know how to jump, that's a basic motor skill. Well, we tend to screw things up as far as form goes as we get older. So let's evaluate, make sure you actually are jumping and landing properly. And then if they're in activities or sports or their job, their occupation, where they have quick changes of direction, train that as well. And even some of your lay people who just exercise for health issues, we have changes in directions too. If you're walking in crowds, you got to do changes of direction. If you're, gosh, I'm in Atlanta, we have construction everywhere. Sidewalks are closed, there's holes, there's this, that, and the other thing. You're changing directions a lot. So that's important to teach even up to your senior levels as well. So stability ball bridges with leg curls. This is looking at a way that you can strengthen those hamstrings. Hamstrings are primary movers with knee flexion. Remember, the gluteus maximus is going to be the primary mover with hip extension. So, hey, let's stabilize hip extension and let's work these hamstrings. And that's what this bridge exercise for leg curl does. If you want to incorporate the glutes at some point in time, then have them lower their glutes down to the floor, lift up doing a bridge, and then flex the knee. But if your client is currently having some knee issues, let's separate the glute and the hamstring exercises for now and really focus on the hamstrings by themselves. So we've got to teach progression. And with all of these exercises that we're getting ready to go through, we've got to make sure that form is correct. Do not be afraid. Fitness professionals especially, PTs, I know you guys, and athlete trainers, you guys do this. But do not be afraid to stop and readjust your client, because if you allow them to continue to do it wrong, they're going to learn it wrong. The muscle memory is going to learn it wrong. And right now, you may be breaking some bad habits with your client, so they need for you to stop and correct, okay? So put your phones away and keep an eye on your client, right? So your progressions with a lot of these exercises, especially with this one in particular, bridge first, straight leg. So start with this over here and just lift up and down, engage the glutes, because your glutes need to be strong enough to stabilize when you do start focusing on your hamstrings in this exercise, because they're stabilizing this position right here and right here. So let's work on the glutes first so that they can stabilize as we work the hamstrings. And you may have seen people, if they're on the prone leg curl machine, that their hamstrings are kind of weak, that they end up kind of flexing their hips in order to lift the bar, to flex the knee to lift the bar. Glute issues. So let's back up the train a little bit. Let's find out what is my client's first step. And that first step may be glute weakness. We know that the glutes tend to be the larger, stronger movement muscle group. And so we sometimes tend to assume they don't get weak, but they do, especially if you've got clients that are always exercising on cardio machines, such as the treadmill, such as the elliptical, such as stationary bikes. Because you move one pedal on the elliptical or the stationary bike and the other one automatically moves. You are on a treadmill and you don't have to propel yourself forward because the belt pulls that leg back for you, whether you want it to be pulled back or not. If that treadmill is on, it's going to pull that leg back for you. So people who are constantly indoors doing quote-unquote stationary type aerobic activity. Even if you're running on the treadmill, your body's stationary, that belt is pulling your leg back for you. So our glutes do tend to get weaker and weaker. And I bet you that if you take a client who is complaining of either hip, knee, or ankle problems, and you have them start with a glute, and again, focusing on glute max exercise, they're going to be like, oh my gosh, I'm so weak. And starting off with both legs is great. Eventually, it's best to do one leg at a time. And that way you can see if there is a difference in the strength between the left glute max and the right glute max. Because chances are, especially if the injury tends to be more on one side on a regular basis, there is a discrepancy, a strength and flexibility discrepancy between left and right side. So we not only need to look at anterior, posterior, medial, and lateral, but we need to look left and right also. So start with those glutes, straight-legged bridge. Then once they got that down and they can stabilize well, and this, of course, let's not forget about core here. They need that core strength. Once they've got that down and they can do good quality bridging exercises, and that may take you a day, a week, a month, who knows, make sure it's good quality. Then you can start adding in this picture on the left where you're now adding in the hamstrings. Glutes are now strong enough to stabilize, core is strong enough to stabilize, hip flexors are strong enough to stabilize, and keep this proper position going so that you can now start to add in the hamstrings. We got a circle here around the ankles. Make sure that they've got good ankle range of motion. Keep an eye on their ankles. Are the heels lifting up off the ball, the stability ball? That may be a flexibility issue that's going on. And if that is happening, then you may need to look at doing some stretches for the gastrocnemius and especially soleus in this case because the knee is bent before they start doing this exercise. Because if you don't, then they're going to start compensating because of an ankle range of motion thing. So that's what I love about our field is it's not just are they doing the exercise correctly, it's where maybe are there issues, and you got to look above and below the injury. And then you got to say, hey, I know all the instruction books say do this first and then this, but my client needs to stretch this muscle group before we do this exercise in order to increase that range of motion in that joint so that their form is correct. It's a puzzle. It's not just, hey, do this exercise, do it like this, there you go. It's a puzzle, and that's where you're really going to help your client, and if you're in a rut, really maybe start enjoying your field again. What you also want to start adding to this is eccentric curls. Slowly progress, slowly extending the knees to really work on the eccentric contraction, the lowering, the down face, which in this case is the straightening of the knee back to this position right here. And keep having them do this exercise. Progress them to one leg. And, again, that may take months with your client, but again, look for quality. Once they can do it with one leg, if you're thinking they can do it with one leg, go back to step number one, which is glute stability first, because now you may be in a situation where the one leg that you're starting off with is that weaker glute side. So anytime you progress, you go back to step one of the previous progression just with the modifications that you made. So step one with both legs was work on glute stability, glute max stability with both legs. And you progressed them to where they now can do the hamstring exercise. Well, now you're going to one leg, you go back to step one again, which is glute stability. And make sure it's not that glute that's the weaker side. Okay, so preventing knee issues, well, we kind of, hit on all of this already. So this is where, and this is a great picture, this is a female. You can tell from other ways, but the reason why she's probably rolling in on the medial side of her foot right here, she's got that Q angle, and it's pulling her femur in, which is pulling the tibia out, which is now rolling the foot in. So when you do your postural analysis or your movement assessment, your person has to be barefoot. They can't have their shoes on because remember, the shoes may be the problem. So have them do this barefoot and see what's going on. So like I said, there's training for those movement analysis functions that you can get into. Not the purpose of this presentation, but I encourage you to get exposure to that. Because again, the problem with your person's knee may be ankle range of motion. Now, a simple little thing that you can do, and I'm going to switch over to this slide right here, and then I'll come back to the other one, is to check ankle range of motion, to check the dorsiflexion. And what you do, and there's different little variations, but basically you have your client stand to where the toe of their foot, and barefoot would be best because some people's second toe is the longest toe. So whichever longest toe is 4 inches away from the wall. And just put a little piece of tape there so that you can use it for the other foot when the time comes. And then you're going to have them see if they can touch their knee to the wall without the heel coming up. If they can, then it said that their dorsiflexion movement of their ankle is good range of motion for that ankle. Remember, you got to check both of them. If they are unable to touch their knee to the wall without lifting the foot up, or they can't touch the knee to the wall and still keep their heel down to the floor, then they've got some range of motion issues going on. What those issues are, start asking your client questions. You know, if they have had ankle injuries in the past, then let's start working on the ankle and then progress up to good lunges and squatting techniques. But you can't have them have good techniques in their lunges and squats in their daily activities if their ankle range of motion is not corrected. And this was kind of a fluky thing, but it is something to kind of think about. There was a client, not one of my clients, but could not do a proper squat to save her life, and unfortunately the trainer she was working with was not even paying attention to her. And you know, you kind of get into that mode of, I don't work here, I'm just a member here, should I say something? And I felt like I needed to say something to the trainer in privacy. And it turns out that this woman has a rod in her ankle. She had been in a car accident, shattered that one of her ankles, and had a rod in it. So here's a dilemma. She's never going to have good dorsiflexion in that ankle. She's never going to have it. So then the question is then does she need to be doing these side lunges and squats that you have her doing, because she's always going to have poor form? You need to modify her movements so that she can still or even change her exercise, modify her exercise. But the challenge is that squatting is a daily activity, getting in and out of a chair, getting up and down off the toilet. So she needs to have a stopping point in the down phase of her squat and her lunges. And that stopping point is always going to be dictated by the weakest link, which is going to be that ankle that you're not going to be able to fix with the range of motion. There's a rod in there. You can't change that. So teach her proper mechanics as far as she can go. And this is where getting your client's history is so very important, that PAR-Q or health history questionnaire. The challenge, if some of you guys are certified through an organization that is a fitness professional that follows American College of Sports Medicine, the challenge, and you know, every organization has its pros and cons, but the challenge with ACSM is they don't really get into orthopedic stuff. NSCA does, NASM does, so sometimes it's nice to cross over to other certifications so that you can get that whole picture. ACSM's great, but they tend to focus on physiological diseases and not necessarily physical limitations. That's just not their area, and that's okay. So that's where it's good to broaden your horizons with other organizations that do, and NSCA and NASM are two that come to mind that are awesome with that, to kind of build your resume and build your education, because that can happen. So, oh, and let me go back to the previous slide here before I get to this other part. So we need to improve hip mobility as well. We got a society that sits a lot. You're probably sitting right now. I know I am. And we can't forget that when 60% of our clients or population do not exercise the minimum times per week, then that means we've got a lot of people that are coming to our gyms, especially, you know, first of the year for their New Year's resolutions, that don't always need to be starting off doing with what they think they need to be starting off doing. You know, even if it's cardio, they need to get some guidance, and it's a challenge because people still think that they can Google this information, and that is something I always ask my students who are wanting to get into our major is, how are you different from Google? Because you're probably going to Google to find out information for this class, but what makes you different? And the difference is we individualize. We see our person. We know that not every exercise that's on the internet out there and every book that we read is perfect for every client. We know how to individualize. So we got to look. Remember we said the other 23 hours of their day. You get a sedentary client, they're probably having hip range of motion issues, knee range of motion, ankle range of motion, because they've been sedentary. So where is our starting point for that client? Let's take a look at them. Let's see them moving. Let's analyze their movement when they're out in the parking lot getting out of their car and walking into our facility, and we can analyze them from that standpoint because they don't know that we're watching them. And we're going to get some good information. We may see some hip range of motion issues, one leg swinging better than the other. Getting out of their car may show some issues with landing mechanics if they do jumping activities, because we're talking about jumper's knee. But there are other issues besides jumper's knee that goes on and that still benefit from everything that we're talking about here. And if they get out of their car and they have to shift to one side to push themselves up to get out of the car, they tend to pick a favorite leg to lead if you have steps. Those are things that should be alerting you that there is an issue going on. And then, of course, that stamina that we have talked about. You know, still got to do their cardio. And, you know, we have people that come into our facilities all the time that, oh, I don't want to do cardio, I just want to do strength training. They need both. So if they're doing their cardio elsewhere, that's great. They still need to do it. So what do we do about improving hip mobility? We tend to exercise in one plane of motion, and I think over the years that has been improving, and this is important for hip range of motion. So we need to get people, if we can, and if it's appropriate, off one plane motion type exercises when it comes to strength and flexibility and cardio and movement in general, because our bodies naturally want to move that way. I know if you've ever heard me in other webinars with seniors, we naturally move in a variety of different directions, and I tend to work a little bit more with seniors now, and one of the things that I have learned over the years, it's not so much what they say they want to do or what they want to work on, it's what you ask them that they don't do anymore and why. And that can signify a problem with mobility. So with seniors especially, I hear things like, well, I don't like crowds. Okay, well, do you not like crowds because of the waiting, the rudeness, or is it because you don't like crowds because you're afraid somebody's going to bump into you and you're going to fall because you don't have multiple planes of motion of movement and stability? Because if that's the reason, maybe I can help you with that. But I've got to get you off that treadmill. I've got to get you off that elliptical or new step or whatever. And we got to start working in multiple planes of motion for cardio, for strength, and flexibility. And this is one of them. So your side stretches in this picture, start in a push-up position over here, this one right here. Step one foot as far forward as possible. And that can be a challenge for some people because they don't have that hip range of motion. But try to get them to step one foot as far forward as possible towards the same hand on that side. So right here is what we're talking about. Lower the hips into a stretch and hold for 2 to 3 seconds, and then repeat on the other side. And you can actually hold 2 to 3 seconds is more dynamic. And switching to the other side, that's great to do before exercise, and just keep repeating, switching sides over and over to make it more dynamic before they start exercising. And then incorporate this as a nice post-exercise static stretch by holding the position a little longer. Have them do some deep breathing, help them sink that hip a little bit closer to the ground, and make that dynamic stretch a static stretch after exercise. You may notice a difference in how far one leg can come forward in relation to the other. And you may say, that was what I was noticing when this person was walking into my facility. It just confirms in your head what may be going on. Now, the picture on the right over here is an adductor stretch, ADD stretch, 2 Ds as in dog. So I always say adductor for that as opposed to just abductor when I'm saying the B as in boy. So for the adductor stretch, start in a quadruped position like he's in, with one foot out to the side over here. Keep the lumbar spine neutral. So make sure your client can maintain that neutral spine. You may need to teach that first, and then have them rock back and forth for a dynamic stretch of the adductors, the inner thigh. So they're moving, rocking this way and this way in order to get into a little bit deeper stretch. So this foot may actually start sliding a little bit more laterally. And again, if you want to make it a nice post-exercise static stretch, just get them into a good, comfortable stretch with mild discomfort and have them hold it for 20 to 30 seconds or so. Hamstring slides is another way that you can kind of work on some range of motion for the hip and also kind of engage glutes and the hamstrings a little bit. Quite a bit actually, because now you're working on eccentric control so that your foot doesn't slip all the way out from under you, and then of course your concentric for the hamstring. Glutes are stabilizing. I bet you some of you guys are saying, oh my gosh, his back is a little arched here. He's still maintaining neutral on this side over here. We're just trying to get some range of motion movement going in this other leg. So he's still in a good position, but that's definitely good eye that you noticed that if you did, and make sure that your client maintains that during the exercise. Also, too, keep in mind his shirt is kind of hanging down a little bit, and that may be, you know, mashing up the image a little bit to where it looks like he's extending his back, but he really isn't if you look at this stabilizing side. But invest in some of these, you know, plates. I mean, get paper plates that are slicked over a little bit, have the waxy surface to it. Those will work just as well if you're limited on a budget. You're shifting a little bit to proper jumping and landing mechanics. And keep in mind, some of you may be saying, well, I only get 1 or 2 exercises. If you've listened to other webinars that Exercise Etc. has, or any other company or continuing ed, you can take any of these exercises and take the basic concepts that we're teaching you in this webinar and incorporate it into those exercises. So for example, let me go back over here. Your client has done that stability ball. Your client started off with that stability ball just doing bridges and stabilizing. This hamstring slide could be another progression once they've kind of mastered single leg hamstring movements with the stability ball. This is another progression. So then shifting to your jumping and landing mechanics. Okay, your clients are going, I know how to jump. I've been doing it since I was a kid. Well, we tend to mess things up as we become adults when it comes to movement. So we need to make sure our clients know to land on the balls of the feet when they're jumping. Excuse me. Immediately sit back to the heels to fire off those hamstrings and help so the hamstrings can help with the knees, with the quads at the knee, and with the hamstrings at the glutes. And flex simultaneously at the hips and the knees. You don't just flex at the knees and then flex at the hip, which is what a lot of people tend to do if you watch them. They need to do it both at the same time. So they're absorbing some of that shock into the muscles and not into the joint. Okay? So balls of the feet, roll back to the flat-footed, sit back on the heels as the knee and the hips are both flexing at the same time. Maintaining neutral. Now, that kind of goes back to something that I've briefly mentioned, and I need to mention it again. Make sure your client knows how to maintain neutral. Make sure your client has good dorsiflexion of the ankle so that they can maintain neutral, because we know that when clients have poor dorsiflexion at the ankle, they tend to flex more at the hip and less at the knee, which in turn starts to weaken the glute max because it's not engaged as much. So all of these things that we've talked about so far, the measuring the dorsiflexion of the ankle and incorporating these exercises leading up to, now let's make sure your client does know how to jump and land properly, because they've mastered all these other things that we've already discussed. So it is sequential, okay? So shifting from knees and hips, let's look at the back. Now, I briefly mentioned earlier that your strains, the T in strain, I always remember, teach my students, the T in tendon, tendons attach muscle to bone, so muscles and tendons work together, therefore that is a strain if they get damaged. And then of course we've already mentioned that sprains are ligaments. So some factors that may increase a person's risk of having back problems: poor conditioning. Well, we just talked about the ankles, the knees, the hips, the spine, core muscles. All of this can affect the back. We really are connected. And so we can't just look at the back problem. We got to look above and below, and that's pretty much every joint. Obesity. Well, let's think about obesity for a second. An obese individual is going to have poor exercise technique. Poor exercise technique is going to lead to poor body mechanics. And obese individuals who are not exercising are going to be poorly conditioned. So it's all connected. Same thing with your smokers, not just the hemoglobin and oxygen binding effect that happens with the nicotine, or that doesn't happen with the nicotine. Therefore, tissues aren't getting the nutrients that they need to stay healthy. Chances are your smokers are poorly conditioned because they're not exercising. Poor condition leads to poor exercise technique. Poor exercise technique leads to poor body mechanics. And keep in mind, when we say poor body mechanics, we're talking not just in the gym, but those other 23 hours during their day. So especially if they have a physical job, nurses, sometimes PTs, that, you're having to help patients depending on where you're practicing, especially if you're in acute hospital settings. Your patients can't move themselves. You're having to do it. If you're in poor condition, if you're obese, smoking, and there's been study after study about nurses who tend to be the more obese in population that smokes, especially in the healthcare industry, and a lot of what they do leads to back problems. Also, too, we got to look at extreme spinal rotation, hyperextension. My students a lot of times get confused. Oh, we can't do extension? No, we can do extension. We don't encourage hyperextension. Now, PTs, athletic trainers, you may have reason to encourage hyperextension because of a way a disc gets herniated. Fitness professionals, myself included, out of our scope of practice to determine that. So fitness professionals, we are extension, avoid hyperextension, unless we are told by the PT or athletic trainer otherwise. So we need to avoid exercises that do hyperextension. And there are a lot of exercises where hyperextension is encouraged. And I tell my students all the time, it's like, guys, if you're telling people not to hyperextend in their daily activities, why in the world are you telling them to do it in the gym? It doesn't make sense. Teach proper form. Muscular imbalances. Well, we just kind of, talked incessantly about that with the ankles, the knees, and the hips, but also with your core as well. And again, keep in mind, muscle imbalances aren't just about strength imbalances. They are about flexibility imbalances. And so my biggest pet peeve with our industry is none of us have perfect posture, yet we exercise as if we do. We do the same number of sets, the same number of reps, on the anterior side versus the posterior side, the medial versus the lateral. And if you've got a client that has postural abnormalities, strength imbalances, flexibility imbalances, then you have to strengthen and stretch in balance. If your hamstrings are weaker than your quads and they're weaker than they should be, then why are you doing the same number of sets and reps as your quads? You're always going to have that imbalance. You need to do something different for the hamstrings so that they can catch up to the proper strength in order to balance out with the quads. So we have to put our person on an imbalanced strength training program and an imbalanced flexibility program, because again, if a muscle is tight, then you need to stretch it more than its counterpart, more than its antagonist. You've got to do it in balance. And we don't do that because everybody's got to be even Steven. And our even Stevenness has not corrected problems. So that's something else you want to keep in mind as well. And then aging. Well, you know, things change as we age, doggone it. So that doesn't mean that we cater to the aging. Age is just a number. I've seen very, very fit 70 and 80-year-olds and very, very unfit 20-year-olds. Age is just a number, but there are some physiological things that are going along with aging. They are less severe if we're exercising and taking good care of ourselves, but they're still happening. It's just the natural aging process. And that can be spine issues, bone issues, arthritis issues that change the structure and build and movement of the body. We have to take all of those into consideration. And again, that's where the pieces of the puzzle come into play, and it's fascinating to me. So when we're looking at strains and sprains, and this is specific, it can't apply across the board, but we're kind of specifically focusing on the back right now. Although if you're looking at knee and ankle, this could apply. We need to know this as fitness professionals because when we start getting into grade 2 and definitely in grade 3, out of our scope of practice, they need to go to their doctor. So fitness professionals, myself included, grade 1 symptoms, tightness in the back, they're able to walk properly, but they can kind of feel it. Sometimes they're stiff, but then it loosens up the more they move, but that's the body telling you something. And if there's any swelling at all, it's minimal. You probably don't even notice it. Grade 2 symptoms, and this is also including those strains, where the muscle may have torn a little bit. Your grade 1, 2, and 3 of strains with a muscle or tendon is the same as sprains. So grade 1, of course, no tearing. You just kind of quote unquote pull the muscle. And again, could be balance issues, strength issues. Your grade 2 symptoms, they're going to have some difficulty walking without compensation. Not good, because that's going to lead to other problems. Occasional sudden twinges of pain during activity. Some swelling may occur, and they may have some pain on palpation. Now, let's talk about palpation here for a second. And a lot of people don't know this, so just need to educate here. Fitness professionals who do not have a degree in exercise science are not supposed to be touching their clients. And it happens. I know some of you are going, oh, that's not good, I do that. And that's, you know, this is the live and learn part. The reason for it is that certifications do not require that a fitness professional with just a certification be tested and in a hands-on as well as a written environment for anatomy and physiology. You're taking oftentimes a computerized test, and you don't know when you've gotten your score results back what you have missed. There also typically is not a practical component. So because of that, liability-wise, fitness professionals who only have the certification and not a degree in exercise science should not be touching their clients. You have not been tested on your knowledge. And that has led to some lawsuits. So we don't want that to happen. And I always tell individuals that have the certification, if you truly love this field, consider going to get your degree in exercise science. And some colleges call it fitness science or exercise physiology or kinesiology. It's all basically the same thing. Get your degree in it so you can do more, because you are limited with a certification. And a lot of certified individuals do not know that. So please know that. So if you have a client who's having back issues, You should not be touching them and saying, does it hurt here, 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 or here? What you need to do instead is say, point to me on yourself where it is hurting. And if it is a grade 2, especially if you are working with your client and it appeared to be a grade 2, but you were able to work with them and it's not getting better, especially if the injury or the pain is getting worse, that's when we, including exercise physiologists, need to refer it out. So if the grade 2 symptoms, you're working with your client in a fitness center, a gym, a wellness environment, you're degreed exercise science and or certified as a fitness professional, and you're working with your grade 2 symptoms and they are getting worse, or they are not improving within a reasonable amount of time, they need to get referred out to the doctor. That is the clear line with fitness professional versus PT or athletic trainers. Your grade 3, fitness professionals, we don't work with grade 3s. Your client is obviously having walking and movement issues. Their face is telling you they are in pain. You're looking at them wondering, why did you come here to work out and not just go on to your doctor? They need to be referred out. There is severe pain. They may have immediate swelling. Any contraction will be painful. You may even see a bulge in the muscle with the muscle strain because it could be a third-degree tear or second-degree tear, and what that bulge is that you're seeing are the fibers that have torn and have kind of balled up. And these individuals, from the fitness professional standpoint, are going to be out of commission 3 to 12 weeks or more because they need to be in physical therapy, or they may be getting surgery. Either way, they're getting physical therapy, or athletic training therapy. That's where they are. And they don't need to be worried about their exercise because we know that when the back hurts, everything hurts. So they need to be focusing on getting well under the care that their physician's telling them they need. So then we do, fitness professionals, we've all probably had to do this many times. You don't need to be here right now. You need to go to your doctor. You do not need to be exercising here. Go get this checked. And they've probably been told that before, but they just need to hear it from you. So what do we do about it? So they may need to rest a little bit, but not more than 48 hours because rest is not a bad 4-letter word is what I tell students, but too much of it is not good. So fitness professionals, if our client has hurt themselves, it's a grade 2. Grade 1, they probably don't need to rest, but they need to be careful with their movements. Grade 2, maybe let them rest, not more than 48 hours. Grade 3, we don't even know because they've been referred out. We're not working with them. They need to control their pain and inflammation, and that is a question they need to talk to their doctor about because we may or may not be aware. I don't really like the Part 2 form that ACSM recommends because it doesn't get into other questions that I would like to ask. I still like the health history questionnaire, and it's one that I designed myself using ACSM risk stratification process, but adding other things that I wanted to ask, mainly orthopedic stuff. But one of the things that could be an issue as far as what pain or anti-inflammation medications your client may be able to take over the counter depends on if they're on things like blood thinners, Coumadin, warfarin, and your PARQs don't even ask about medication. So that's where sometimes fitness professionals, it really is a consideration to consider getting a degree in exercise science because you do learn about this stuff because there's the back problem may not be their only issue, their only health issue. So if they are on blood thinners, Tylenol is really the only thing that they can take. Aleve, Advil, aspirin all has aspirin in it, and aspirin thins the blood more. But that is not for a fitness professional to even suggest. Say, are you on blood thinners? Yes. Okay. Has your doctor given you an over-the-counter anti-inflammatory or pain reliever that you can take while you're on your blood thinner? What is that? Well, it's Tylenol. Okay. Well, follow your doctor's recommendations on that and, talk to them. So when it comes to putting anything in our mouths, and this is kind of a nutritional scope of practice for fitness professionals, we can't give them any information other than best to go back and talk to your doctor or your dietitian in that case. You've got to know your client's medical history, including medications that are taken. The third bullet point, see a professional to determine which tissues have been injured. Rule out more severe injuries or conditions. So let's say you're thinking your client has a grade 2 and it's not getting better. Well, let's send them to the doctor to rule it out. Or if your client says, you know, you're back over here to that grade 2, you're thinking it's grade 2, and your client is having these sharp pains. That, or radiating pain. That's one thing that's not on here. Radiating pain. That's nerve. Out of the scope of practice of fitness professionals, that needs to go to the doctor and ultimately to a PT or an athletic trainer. So, whoops, didn't go far enough. And then following inflammation phase, encourage movement. If you're able to work with your client, it's within your scope of practice, we need to encourage movement and gradual return to activity. Gentle movement. Maybe take the weights off if they're doing strength training or very, very lightweight. Keep them under that pain threshold. And I actually tell my clients right off the bat, you know, if we're going to gradually get you back into activity, we are going to make today so easy that you're going to complain that it's too easy. And I'm okay with that because it's not what we're doing right now, it's how you're going to feel tomorrow. And if we have overdone it, you're not going to probably notice it right now. You're going to notice it tomorrow. And then you're going to be really mad at me, and I'm going to feel really bad. So we're going to do it this way and take it really, really easy on you. And if you tell me tomorrow or the next day that I had no problem and it really was easy, then I'll start to gradually increase. But we're going to start it off really, really easy in the beginning. And that includes your stretches. Don't force the stretches. Don't force, oh, gee, I need to stretch this out. Well, you know what? It goes back to what we've been saying about imbalances, and they may be stretching the muscle that is already stretched beyond its ability, and that may be why they have the back or the hip or the knee problem right now. So if you haven't done some type of postural or movement analysis on your client as the back injury has improved or whatever injury it is, now's the time to do that. Oftentimes people think they have back problems because their hamstrings are tight, because they quote unquote say, I can't touch my toes. Well, you know what? You can not touch your toes because your hamstrings are so freaking stretched and your hip flexors are so tight, and by trying to stretch your hamstrings more, you're making your problem worse. So I always tell students and clients, bones don't lie, and that's where postural analysis that I tend to teach is your bony landmarks are going to say, nope, not the right place because we got an anterior pelvic tilt or a posterior pelvic tilt or a high hip or whatever. Your muscles, 99% of the time in my experience, is the muscle that's hurting is the one that's stretched and weak, and that's why it's hurting. So might be worth it to do a postural analysis. So some exercises following sprains and strains, cat-camel exercises, which is what this is, the mad cat where the back is arched. In this position where the spine is flexed to help stretch the erector spinae muscles and the deeper muscles, the transversaria and the multifidus and rotatory and all that good stuff, but also get the quadratus lumborum, that lower back muscle. Be careful, though, if your client has osteoporosis because of this right here. So you may need to look more, if that is the case, at some of your hip stretching. But which hip muscles? Well, postural analysis. Chances are you might find hip flexors are tight, glutes are tight, hamstrings are stretched and weak. So this also means that you need to get into strengthening exercises for what's stretched and weak, flexibility exercises for what's tight. And then your bird dog exercise, some people call it the quadruped exercise. You're down on your hands and knees like he is, but you're keeping the spine in neutral. And what you're doing is you're lifting one arm up while keeping the spine in neutral and then return the arm to the starting position. And you can have them repeat however many times, 8, 10, 12 times on one arm. Have them do the same thing on the other arm. If they can maintain neutral, while doing the arm movements, then you can start to add in the leg movements where you're extending the hip and the knee, maintaining neutral. Sometimes people will put a broom handle or a little PVC pipe across the spine, and if it falls off, they're not maintaining neutral. Once they can do the arms individually and the legs individually, then you start to add opposite arm, opposite leg. And again, this may take days, weeks, months for your person to do it right. Once they are able to alternate opposite arm, opposite leg and maintain neutral, their next progression is back to just arms again, back to that first step, but now they're on an unstable surface. Maybe they've got the balancing hand on a Dynadisc. And then maybe add a Dynadisc as a progression when you start to get to the legs underneath the balancing knee. And then once they're able to alternate arms and legs, opposite arms and legs at the same time, a Dynadisc on the knee and the hand that isn't being used. Then you can progress them further. All four are on a Dynadisc. So there is a progression from arms first because they weigh less than the legs, so it helps to maintain neutral. So arms first, then legs, then one arm at a time, one leg at a time on stable surfaces. Then you switch to a moderately unstable surface and go back to your first step like we talked about before. Start with just the arms, then progress to just the legs, then opposite arm, opposite leg. And then you can add more unstable surfaces as you go along. So progression indeed. So now let's talk about rotator cuff tears and the shoulder. The shoulder is very unstable. It doesn't have a nice deep bony socket like the hip does. So we've got to rely on labrum that helps deepen that groove into the glenoid cavity in the head of the humerus, and then your rotator cuffs and other muscles, but mainly the rotator cuff muscles to help stabilize that joint when it needs to be stabilized. So if any of those muscles are weak, you have a stability issue. So rotator cuff tears and injuries, lots of overhead sports or movements, mechanics, car mechanics when they're underneath the car, electricians, construction guys, it's not just sports. Or the person has a fall with outstretched arm, and which can actually dislocate. So that's also, history of dislocations or subluxations. Subluxations are partial dislocations. So when your client says, I can dislocate my shoulder and put it back in place, no, if they dislocated their shoulder, they're in agony. They're probably partially subluxing or partially dislocating their shoulder. And that's not good to do because that probably means they have some rotator cuff stability weakness and or a labrum tear, and that labrum tear is making the head of the humerus move around more in the socket than it should. Overuse or degeneration, arthritis. And then, of course, your symptoms, pain with reaching overhead activities, may also have some weakness in one arm more so than the other. And depending on how torn it is, sprain or strain, because you got some ligaments in there as well, it might require surgery to fix it, especially if they sublux a lot. The more they sublux, the more they just need to go in there and get that fixed. Or it may require physical therapy, athletic trainer to work on them, especially if there's a second degree 2+ tear, definitely post-surgery. So some causes of rotator cuff dysfunction, weaker external rotators. And if you remember, your external rotators are infraspinatus and teres minor. They become weak because we tend to become slouched and internally rotated. So our internal rotators become tighter. The external rotators become stretched and weak. And when it comes to internal rotators that are tight, we don't want to forget pec major, latissimus dorsi, and your anterior deltoid. So now that means your infraspinatus, your teres minor, and your posterior deltoid are weak, and the deltoids get forgotten sometimes. So if your client has excessive cervical lordosis, excessive thoracic kyphosis, which unfortunately we see in osteoporosis, sorry, I had a little brain lapse there. There's not a whole lot we can do if it's structural, if it's just the way the spine grew, or the disease made the spine grow. but we might be able to lessen some of the pain that they may be having by still working on external rotators, but carefully. And then excessive internal rotation. So people who drive a lot in their car, you're internally rotated holding onto the steering wheel. People who are on their computer, like you may be right now, that is internal rotation. That's tightening up the pec, tightening up the latissimus dorsi. It's tightening up all of this stuff. So we're not saying don't do this stuff. We're saying balance it out. Stretch the internal rotators, strengthen the external rotators more so than you normally do. All about the balance. So the cuff is reactive. So in strengthening the external rotators, integrate some of your proprioception training, such as using pendulum swings, where you're, or circles with a light weight or circles with no weight at all to start off with, depending on how problematic their shoulder is, and work on moving the arm while those muscles are trying to stabilize the shoulder. And then as they get stronger, you can make the circles bigger and bigger. Then you can go back to your starting point like we've been talking about with progression, and then add a light weight and work on pendulum movements or circular movements, getting bigger and bigger and bigger within reason. And then increase the weight again. And, you know, again, that may take days, weeks, months. This is useful during periods of acute injury to help retain mobility, but again, if it's acute, they're probably at the PT or the athletic trainer, not with the fitness professionals. So again, it's important for us fitness professionals to work with the PT or athletic trainer and find out what their last session was so that we could take that and start to hopefully progress even further. Do not increase tissue damage with the pendulum because there's relatively, the movements, the pendulum swings and the circles don't increase tissue damage because there's very little muscle activity when you're performing these exercises. It's just kind of keeping things mobile. Your passive range of motion exercises that gently distract the humeral head from the glenoid fossa can be helpful. Again, talk to a PT about that first if you're a fitness professional, or talk to your athletic trainer. It gently strengthens the tendons and the muscles that provide stability to the shoulder joint. And basically, this is called gyrating motion of the hips, similar to spinning a hula hoop. So you're swinging the arm into flexion and extension initially, and you progress to figure 8, abduction and abduction. But they're also great preventative exercises for overhead throwing athletes, especially if you're an athletic trainer or you're working with athletes. But if their shoulder is healthy enough, you want to use a little bit more resistance, like maybe 15 to 20-pound dumbbell if they don't have their injury and you're using it for prevention in its appropriate weight. This is also something that for those of you who may be working with cancer patients that have had mastectomies, they're done with physical therapy, this helps kind of keep their range of motion going with that pectoralis major too, because a lot of scar tissue built up in there. Also with the figure 8 and movements with seniors, because of arthritis, I use scars. And because they don't realize they're exercising, they're having too much fun playing around with their scars. So that's another way that this can be incorporated for a different age group. You need to improve internal rotation. We don't want to do what we call the sleeper stretch. We need to be careful. A lot of times people will think that they're stretching posterior shoulder muscles by lifting the elbow up so much that they're basically taking their arm and wrapping it around and patting the back of their shoulder. And that was actually a cue that we used to teach. We don't want to do that. We want to keep the scapula stable in this. So I have clients kind of roll their shoulders back, stabilize the scapula, keep the elbow below shoulder level, and you'll realize your movement of the arm that you're stretching is only going as far as this in the right picture. If you're going further, you're moving the scapula and you're not focusing on the posterior shoulder muscles for the stretch. So teach stretching properly. Your external rotation against a wall, this will help with range of motion. So you want to make sure that the humeral head isn't moving anteriorly So you can do that by placing your client placing their hand right at the shoulder joint and pressing the elbow up against the wall like he is in this left picture, and then just rotating so that the posterior side of the hand, the dorsal side of the hand is touching the wall. It may take some time for them to get this range of motion, but that is a nice way to help work on external rotation and also provide a little bit of a stretch. Sideline dumbbell external rotation for strengthening those external rotators. You do want to place a towel up against the side of the body and the arm, and that helps to get your humerus more vertical, because if you press it towards your body, especially females, because we tend to have narrow waist, it tends to adduct the humerus too much, and that puts a lot of pressure on the rotator cuff muscles. So put that little towel, rolled up towel, pillow, something in between the arm that you're exercising and the trunk. And EMG studies have shown that this is a great exercise to work your external rotators because it really helps to kind of isolate these muscles. So getting the infraspinatus and the teres minor activated because they've been stretched for so long, they don't know what to do. So we got to re-educate these muscles. Then you can progress them up to bilateral tubing rotation exercises. Some people call this the no money exercise because the position of his hand and the end position, you look like you're saying, I don't have any money. So you're keeping the elbows kind of not up against the body, but close to it, so that you are keeping the humerus kind of more so in a vertical position. So you're getting that external rotation movement, really engaging and stabilizing the traps and the rhomboids and stabilizing the scapula while you're focusing on your rotator cuff external rotators. And then rhythmic stabilization exercises are also very helpful. This is where and I don't know if you can really tell in this picture, but your client, this is a great starting exercise, have them supine and stabilize. And she is holding one end of a band while her trainer is holding the opposite end. He is pulling her in different angles. So he's going to pull her this way, move the line, this way, this way, this way. You can also pull this way, all the different angles, and she is trying to stabilize it. You can also do a progression once they get down and dirty with this, and they can do it great. You can progress them to quadruped stabilization exercises. So she's in kind of a modified push-up position, but now she's on balls. And he's just gently pushing against her hands, and she's having to stabilize up here at the shoulders. Of course, you got to have good core strength to maintain your core here too. She's trying to resist his gentle movements and pushes against her, but she's on a very unstable surface at this point. So start this one first. This can be a progression, and actually a better progression is to work on the uninjured side first with the ball and keep the injured side flat on the floor with this. And then progress to where your both hands are on the ball. And yoga push-ups, again, the key is stabilization. So you've got to make sure that your client, and this is so important, is have them roll those shoulders back, stabilize the traps and the rhomboid, and then get into this yoga pose. This is advanced, so make sure they have progressed and mastered those other exercises that we've done. But this is also a great activation of serratus anterior. It helps improve a little bit of your thoracic mobility because our lower back, and this kind of gets into lower back exercises as well as shoulder, rotation isn't bad. Trunk rotation isn't bad if it's taught properly. The problem is that people try to rotate at the hips, and the lumbar vertebrae are not designed for movement. They're designed for stability. So if we can get some thoracic rotation mobility going, then that's going to help their back, and it also helps them utilize the shoulders in a more stabilized movement for throwing activities and overhead activities. So we don't want to forget about thoracic mobility either. So compression of the shoulder, rotator or shoulder impingement issues, sometimes this is a structural abnormality that's going on. Sometimes it's the muscle weakness. Supraspinatus, it's the rotator cuff muscle that doesn't rotate because its job is to initiate abduction up to about 40-45 degrees before middle deltoid takes over. Long head of the bicep tendon can get impinged. Long head of the bicep tendon comes up through the bicipital groove and attaches to the supraglenoid tubercle on the, or the top little pokey outie of the glenoid cavity. And your subacromial bursa sac, which is what is outlined in yellow in this picture. Certain movement can make it hurt because it's hitting on the acromion process. The bursa is hitting the acromion process. Then when you get to about 45 degrees to 120 degrees of abduction, it doesn't hurt anymore because it's in alignment with the acromion process, the bursa sac is. And then when you go above 120 degrees, it starts hurting again because it's the bursa sac hitting the acromion process. So that's where the structure of your acromion process can increase your risk of having impingement problems. And the only thing you can do with that is sometimes surgery to go in and shave some of that down. So you've got your classifications, your type 1, your type 2, your type 3 based on the shape of the acromion process. And so primary impingement is predominantly caused by the structure of the subacromial region in the acromion process. Your secondary impingements occur without any specific alterations in the shape of the acromion process, but mainly due to dysfunctional shoulder biomechanics, which is going to be muscle imbalances, scapular dyskinesis, or poor movement of the scapula, again, due to muscular imbalances, poor exercise techniques, overhead or overuse, doing too much of a good thing. And then can also be secondary to anterior shoulder issues, mainly laxity, which is more common in women, and often pre-existing cases of chronic shoulder subluxation. So getting that client's history is very, very important. So how do you prevent it? Well, improve the scapular stability. Get them to roll those shoulders back and stabilize traps and rhomboids as they do movements. Chances are they're using trap and rhomboids to add to the movement, and they're going to get weaker and weaker as far as stability goes. So we need to work on trap rhomboid stability. We need to improve thoracic mobility. We're going to show you some exercises on this. We need to reduce wing scapula, and this is a good picture on the left of wing scapula. This one right here where you get into like a wall push-up position so that you're trying to adduct the scapula towards the spine, and one sticks out like a little bird wing, and that's usually a weak serratus anterior, and avoiding excessive overhead activity. So take some of your overhead exercises out and make them shoulder level or below, especially if they already have to do a lot of overhead movement for their job. Why add to it? So improve the soft tissue quality. Release shortened muscles with self-myofascial release. We got a whole webinar on all of that. Work the pec minor, work the posterior capsules you can put a little soft ball and use that to hit pec minor. Again, going back to your anatomy, know those origins and insertions, ribs 3 through 5 in the coracoid process. Here you can see the little ball that he's using. Tennis ball would possibly work, but something kind of soft and squishy for this one so you don't get into a bad position, and help hit the infraspinatus and the teres minor, again, making sure that you know your anatomy of where they're located. Stretch the subscapularis. Take a broom handle, a PVC pipe, or even a towel will work with this, but both hands have to be behind you. And grip the handle, upper hand. Use the lower hand to pull forward so that the upper hand is going backwards so that you're getting a nice stretch. Do the same thing with the towel. Just take both hands like you're doing an athlete scratch test and pull down or pull up, depending on which movement it is that you're trying to stretch. Those are some great ways to do that. Broom handles are easy to come by. And then your side lying windmills to get your thoracic mobility going. Have the leg braced so you're taking care of your back. Have your starting position, one hand on top of the other, but make sure you're in good alignment here. And then rotate the upper arm posteriorly. You can bring it horizontal abduction, or you can bring it up above the head. Do both movements to help work on some thoracic mobility. And make sure, too, that you're keeping the body in good alignment and this leg is not lifting off. Otherwise, you're rotating with the hips and the lower back. And then wall shoulder flexion exercises, your Ys, your Ws, your Ts. Use your wall as resistance. So have your person kind of leaning up against the wall, heels about 6 to 8 inches away, and bring the thumbs. And you can see it really well in this picture right here. Touch the wall above your head and behind you with your thumbs to work on some shoulder extension movements. And as you're lifting up, shoulder flexion movements while keeping the scapula stabilized. So again, you may need to cue your client to roll the shoulders back, really anchor and stabilize the scapula before you do these movements. You can get into some wall sliding exercises. Slide at 135 degrees of angle right here to stay in the line of pull for the lower traps. Lower traps can cause lots of problems, and we don't always strengthen. We strengthen upper and middle traps doing shrugs and rows, but there's a handle on your row machine that are vertical, and that vertical one is to help work, the vertical hand grip is to help work the lower traps, and we don't always, recommend that for our clients. And then for concussions, and I know I am going over, so you're getting some free education here. Concussions, we fitness professionals typically don't see concussions, but athlete trainers, PTs, especially athletic trainers, football, soccer, we're seeing more and more concussion issues, and so we do want to be aware of concussions. So ATs, PTs, this is you guys. We know that with impact to the head, acceleration, deceleration forces is what's causing concussions. The brain is just floating in its cerebrospinal fluid, but the force of the brain hitting, and basically, a doctor explained it where if you take a bowl of Jell-O and drop it on the floor, the bowl doesn't break, but the Jell-O just hits all over the place in the bowl. That is like your brain with these excessive forces. It's just bouncing off one part of the skull to the other. And you guys have all kinds of, meaning PTs and ATs, have your techniques of how to evaluate in field conditions, whether you suspect your person has a concussion or not. And you know what to do following your licensures, which is basically pull them out of play and do further testing on them to make sure it's not an emergency. Now, here's where we're saying call 911. Well, it depends on the situation. We know that if you suspect a concussion with a player, you pull them out of play, you keep an eye on them. But if they start showing signs and symptoms of something like a more serious concussion, loss of consciousness, that thing, yes, you do call 911. You've got an ambulance most likely at your sporting event, and you need to get that person to the hospital. Because they're beyond observation. They got something else going on in addition. Now, fitness professionals, and maybe PTs, depending on the environment that you're in, if you're suspecting, maybe your client slipped and fell in the gym, hit their head, if, for fitness professionals, call 911 anyway. Even if the person's like, I'm fine. But if they're starting to show, keep an eye on them. If they're starting to act a little confused or acting, quote unquote, differently than normal, call 911. Because it's between the client and the EMTs or the paramedics as to whether that person goes in the ambulance. You have done your job to try to get them proper help. But like I mentioned, PTs who are also athletic trainers that also work at sporting events, athletic trainers especially, are really, for me, my go-to, if I'm suspecting a concussion with somebody, because they're trained in looking for it because they see the acute issues. And they know when they need to send that person to the hospital while the game continues on or not. So if the neck is injured, you got to stabilize that person. If the neck is not injured, try to have them sit upright, decrease intracranial pressure by sitting upright. But if you suspect a neck injury, don't touch them. Fitness professionals, ATs are trained in neck bracing and PTs are trained in neck bracing. They know what to do. And then, of course, return to activity. Again, PTs, ATs, you guys got this down. That's why you are a PT or an AT. You're licensed to do this stuff. Fitness professionals, you need to get a release form, and strength and conditioning. We need to get a release form from their doctor, from the trainer, from a licensed healthcare professional saying that they're cleared to return to activity. Strength and conditioning, guys, you sometimes may, and athlete trainers, you may have to fight the coaches on this sometimes, and you guys know that better than all of us. You know, but got to care for the athlete first. So I went over, consider it free learning. But if you are interested more in concussions, we do have a webinar, and I'm sure there are other companies that have webinars more on concussions. But fitness professionals, even if you listen to those lectures, you still probably cannot do what is being taught in those. It's good to know about it, because then you can ask your client, well, did they do this, that, blah, 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 to help you understand where your role is at that point in time. But please know that as fitness professionals, if you listen to those webinars, that's great, but you got to be a licensed athletic trainer or PT to do a lot of the information that's in some of those webinars. Our job is refer them out. When in doubt, refer them out. So here's that last page. You know, again, go to the Exercise Etc. website and click on the administration button or link and go to the webinar on demand. Type your name in on your certificates the way your credentialing organization has your name, just to keep lines easy and clean as far as getting credit. And then again, remember, if you fast forwarded through the webinar, you may not get your continuing education credits, and hopefully you didn't do that. And then again, hopefully you've just finished this presentation, but do make sure you print off your certificate with this year's date on it to make sure, again, that you don't have any problems with your credentialing organization. And for your post-course learning assessments, some of you do need to take this, so if that is you, hang on with me here. Let's go through this. I'll give you just a couple of seconds to answer. So question number 1, got a piece of paper out, write your answers down. Question number 1 with your ankle sprains. And actually, you guys go through this on your own, but question number 1 with the ankle sprains account for 1 out of every blank visits to the emergency room. You'll write your answer down for that. Question number 2, all of the following are appropriate recommendations for the management of patellar stress syndrome except, so which one does not? You're going to write your answer down for that. Question number 3. And again, if I'm going too fast, you have these printed out so you can answer these later. Some difficulty walking without compensation is a symptom of what grade of sprain or strain? Question number 4, your EMG studies have shown that the best exercise for external rotators of the shoulder is what? And question number 5, which of the following is not an appropriate method to prevent impingement of the shoulders? So you do have the answer key in here. Again, you can do this on your own since you have printed this out, and you are going to make sure that you keep the assessment with your other recertification documents for at least 4 years. That usually covers most organizations. And if you have any questions for exercise, etc., and here's the answer sheet, email them at info@exerciseetc.com. And I appreciate you guys hanging in there with me as I went a little bit over. And I hope you got a lot out of this presentation. Thank you.